So again, today, I believe, correct me if I'm wrong, Dr. Genta, you were the addiction fellow last year, correct?
Correct.
Yeah. So we're excited to have her here today to talk about food addiction, fact or fiction. This is a bit debatable. It'll be super fun. I'm Kurt Devine. I think everybody knows me and my colleague, Aaron Voss, who helps with all of this.
We have some great upcoming sessions. Be sure to log in next week. Kurt's going to be doing a talk on pregnancy and marijuana. If anyone would like to do the talk on July 10th, we're open. So let us know or reach out to Katie if anyone wants to step in and do a presentation. And then July 24th, we have a nice talk on the PrEP, which is pre-exposure prophylactics. I can't talk today. I'm not caffeinated enough. Oh my goodness. Just on HIV prophylaxis integrated into primary care. And then the Charlie Resnikoff is coming back on August 21st, and he's always awesome. Also at the bottom of the screen, there are other Echo series that are available for folks to check out. So if you're curious about them, take a look.
All right. And remember, there's free CME. Just make sure you answer Katie when she emails you. I think I already said it was free. And remember, we love to see people's faces. And I think Dr. Agenta would love to see people's faces when she talks so that there's not just big black boxes. So if you're able, please turn on your video.
And just a reminder, if you need any assistance or advice on any difficult cases, program implementation, policy, protocol, don't hesitate to reach out. Our contact information is listed below.
And lastly, there's the Core Center for Opioid Resources. You can go on there, find all kinds of fun things and protocols. Try not to reinvent the wheel if you don't need to. So feel free to check that out. All right. Well, with that, Dr. Genta, maybe we'll let you do a little introduction of yourself as well. Maybe tell people what you really do and what your days look like. And then we'll move on to the talk. So thanks, everybody, for coming.
Thank you, everyone. So I'm S.A. Agenta, family med trained in Hennepin, and I've been a hospitalist for over 6 years now, but addiction medicine has always been a love of mine. And so I went back to fellowship and finished last year. So I'm still practicing full spectrum, so inpatient, full-time hospital medicine. But I'm also a deployment of the American Board of Obesity Medicine. So if you can tell, I love to learn. I wanted to know more about obesity, wanted to know more about addiction and how to help my patients. And so it's something I find very interesting being in both of these worlds. And when they talk, I'm like, there are so many similarities. So I wanted to explore this topic and excited to share it with you.
So did you want to share your own screens?
Yes, let me try. Let's see if this works out.
Don't feel pressured, but I could not do this. This is just, this is where I'd fail right here.
She did it. Look at her go.
Let's see. Okay, so we're exploring food addiction. Is this real? And let's see if I can move the slides. No, the problem arises. Okay, so today we'll be trying to identify what is this concept of food addiction. And in order to talk about food addiction, we have to talk about foods, because is it all foods that make people addicted, or are there particular foods? So we started talking about ultra-processed foods. You can't talk about food addiction without talking about ultra-processed foods. So we need to find out what are these and why is this important, right? We have patients who are dealing with eating disorders, overweight, obesity, other comorbidities. And if you, as a clinician, think, can my patient have food addiction? There are ways to go about trying to figure that out. So I wanted to start with a case, just to get us thinking about this concept. Like, it's not really foreign. This can be any patient who presents to our clinic. I'm talking about Sarah, who's 45, high functioning. She's an executive, pretty healthy all her life, recently got promoted, and now she's starting to notice a few changes in her life. She had an annual exam with you, and they're like, frequency's a little high. I think you're pre-diabetic. And her weight has gradually increased. She has no history of substance use, no psychiatric diagnosis. Once in a while, she'll drink a glass of wine. So you talked with your patient and said, there's data on metformin, right, for prediabetes, or you could try lifestyle changes. And she's like, how hard can this be? I can try lifestyle changes. But it's been 6 months. Her A1C is on the rise. Her weight is on the rise. And she's starting to identify certain things that make it harder to stop eating and stop eating certain kinds of foods. And she's been reading a lot, talked to you about it. And you told her, hey, why don't you keep a food journal? I start to see, do you have any cues? Are there particular foods? Are there particular situations that cause you to eat more? And she's starting to see several things pop up as she starts to be mindful and keep a food journal. And so some questions as we go along. Could this patient have a food addiction? If you were her PCP, she came to you and started to ask questions, maybe I'm addicted to food. How could you evaluate her, right? And how could you talk to her about this ultra processed foods? So the diet in America has changed over the years, starting around 1970s, 1980s. There were industrial processes that were created, right? We could make foods more palatable. We could make foods more inviting. And so there are several definitions out there. We're still trying to come up with what's the real definition of food addiction. Most things that are common in the definitions is that, hey, these are foods that have gone through so many industrial processes. They've been broken down into their almost like to their components. So fats, we're talking fats, sugars, salt, and put together in high concentrations, right? That and even put in with additives that make the food more appealing. My husband even said, hey, I was watching TV and they were talking about those ultra processed foods. And they said, these are food substances that you don't regularly have in your kitchen. You're not just going to get it off your shelf and put it together. No, these are foods that have gone through industrial processes. So in order to kind of help people think through these foods and also to help to do research, there's been a NOVA food classification. And through time, right, through centuries, humans, we've always processed foods. We've done salting and canning. And so we're not talking about foods that are still foods in their very nature. So like minimally processed foods. No, these are on the other scale. Some of them, when you look at a package of food, or you're reading the food information, you're going to see a lot of words that you don't know, you don't recognize. And some of these are like chocolate and ice cream and frozen pizza, things that you see every day in the grocery store. And why is it important to talk about these foods? These foods, why is it now making up 57% of our diet? It's easily accessible, right? It's very convenient. We are working harder and harder. We have less time to make a nutritious meal. We have less time to spend hours trying to cook food. And so these foods also have unnaturally high levels of these components. So in nature, we don't really find fat and sugar together. And we'll be talking about this more. Like you see either high fat like salmon, you see high sugar like berries. But when you start to talk about foods that have both of these, like ice cream, having sugar and fat, and that for the brain is just so much more than any food in nature. And so many of these ingredients are metabolically active, and they can trigger reward pathways. So we'll be talking about that more. One of the things that was very interesting to me, because I've been doing some work with Dr. Reznikov on nicotine, is that our tobacco companies several years ago started to own many of the food companies. And these companies are people who have so much knowledge about how to make a substance addictive, how to make people want a substance, right? So nicotine, think of nicotine. It's like, it's there, I want it. They have figured out how to make that more appealing to people. And so they applied some of that research with nicotine to foods. And that's something to think about. And tobacco companies have also been known for targeting children and minority populations. And it's the same thing with foods as well. So what are the consequences of ultra-processed food? There's data, showing that they're related to higher rates of overweight, obesity, metabolic syndrome, cardiovascular disease. So that's why we're here today, right? That's why we're talking about this, because it's important. So now we've talked about ultra-processed foods, and now to get to food addiction. It's very controversial, the concept of food addiction, because there's no DSM-5 criteria. In the last 20
shouldn't rule everything anyway.
In the last 20 years, though, there's been a lot of research. The amount of research has exploded in this area. And so what we find is that the concept of food addiction, the overlying concept, is it initially started because people were interested in they started to see similarities in there are certain behaviors with food that some people have that are very similar to behaviors that people with addiction have. And when you think about the DSM-5 criteria, loss of control, tolerance, cravings, you can see that with food. And food addiction is also very related to eating disorders. And so it's the definition right now is specific food-related behaviors where people continue to eat excessively these high-calorie foods, so this ultra-processed foods, and are unable to stop. And if you think about the definition of addiction, right, we talk about use despite negative consequences in its simplest forms. So are we seeing people who are continuing to eat certain foods despite negative consequences to their health? And we are seeing those. So there is a hypothesis of how did we come about having problems with food. Our ancestors had to forage for food. They had to hunt down animals to get food. And so our brains had to remember, for instance, I found some berries at that location. Our brains had to remember that. And so when we talk about our reward systems, we eat food. So for example, I found some berries, I ate them, they made me feel really good. So my brain's going to remember that, and I'm going to trace my steps back to where I found that yesterday. And so one of the main hormone we talk about in terms of reward and motivation is dopamine. So remembering that food that gave you satisfaction and being motivated to go seek it. And so we'll have memory of how good that felt and cues in our environment to remind us of where that was. The issue is nowadays we don't have to hunt for food. Food is easily accessible in certain places, right? We'll talk about food deserts later, but food, not even nutritious food. So we're not talking fruits and veggies. We're talking of every food imaginable is within your reach. You can go to the grocery store. You can order food on your phone. And so these are constantly around us. I have to drive past several donut stores on my way to work. I have to pass by several stores that remind me of whatever pleasure I had gotten before. And on days that are stressful, it may be hard to drive past them without stopping. So it's that mismatch we're getting with the modern food environment. Think about when you've done great all day, right? I had a stressful day, but I ate that salad and I packed to work. And then you're sitting in front of the television after a stressful day, the kids are down to bed, and then you're watching TV and an ad comes up. It's almost always a food ad, food and meds. And so you're going to be triggered. And you may think about, oh, let me just get a bag of potato chips. And before you know, you're finished a bag of potato chips without even thinking about, was that really enjoyable? Did I need to eat till when I was so full? And so we're also finding research that is showing similarities between substances of abuse and food, especially and ultra processed foods. So we're seeing activation of the mesolimbic dopamine pathway, and there are studies that show these similarities, right? And these foods, these ultra processed foods, hijack the reward center. And a lot of the studies have found certain behaviors, like compulsive like behaviors, that cause an individual to want to seek out that food. And so we'll be looking at, I want to take a minute and talk about evidence that we have. And so most of the evidence comes from rodent studies, so rats, looking at rats, because with rats, you can control the environment, right? There are rats that have never been exposed to sugar. And so you could do research on them. And so Avina and her colleagues looked at high sugar. So high sugar diet. They developed an animal model. They gave some rats sugar only. And they started to see that those rats could develop tolerance. They started to have withdrawal symptoms when they were giving naloxone or when they were fasted for about 36 hours. So that anxiety, depression, even some somatic symptoms. And then Johnson and Kenny also looked in 2010. They studied rats using hyperpalatable foods. So we're talking pound cake, icing, bacon, foods high in fat, high in sugar. And they started to see in these rats, they put them in 3 groups. Rats who were exposed to the regular chow. So chow, which in the lab, you're regularly like a salad, it's nice, the rats like it. When they have not been exposed to anything else, they don't know anything else. So they put a group with regular chow. They put another group restricted to 1 hour a day of this hyperpalatable foods. And the third group had easy access. So with the third group, they noticed that, so the rats who had easy access to everything all day, they noticed that this rat started to gain weight, and that they started to have changes in their brain. When they looked at the dopamine levels, they actually found that their dopamine D2 receptors were downregulated, just like we see in patients with addiction. And the rats who had that 1 hour a day exposure to those hyperpalatable foods, during that 1 hour, they would binge on those foods. So almost like a compulsive behavior that you can see in some eating disorders, that you can see in some addictive disorders. And so you can see changes in the reward stimulation pathway with these foods. And so those are most of the studies that we have using rat models. Why would anyone want to use a substance? You know, looking at nicotine, it's available, right? It's acceptable, it's perceived as safe. This is food. Why would anybody think that it's harmful? But we are seeing the harm over the years, looking at data across the country, across the world, right? Even in developing countries that are still dealing with infections, we're starting to see effects from having this other diet, this new culture, in addition to what they grew up with. So you're having both infection and metabolic diseases in developing countries. And so think about in America, as our diet has changed, as our use of sugar. So in like the 1970s, it was about a pound of sugar a year that people would be exposed to. And some years later, like 10, 20, 30 years later, we started to talk about 120 pounds per person. Although now we are seeing with a lot of education, the amount of sugar that people eat in a year is starting to decline, because we're starting to think about this more. Like, I don't want to keep eating sugar if it's harmful to me. But as long as the substance is easily accessible, it's acceptable. It's something that we celebrate, love and good health and things with food. Why would I think that that is harmful? Why would I not want to eat these foods? And so in 2009, Ashley Gerhardt is a food scientist and a psychologist. And so she started to look at, with her colleagues in University of Michigan, started to look at food addiction and trying to measure it. And so they created the Yale Food Addiction Scale to try to evaluate food addiction. And so in 2009, they created the first one, and this was based off of the DSM-4. And so when DSM-5 came out, they updated the YFAS to a YFAS 2.0. And so it's 35 questions. It measures the 17 substance use disorder criteria. So loss of control, withdrawal, craving, tolerance is based off of that. And they even have short forms now, which are about 11 questions, called a modified YFAS. And there's YFAS in children, for children as well. And this study, this addiction scale, has been validated. And apparently it's been used in every continent. So most of the studies on food addiction are based on this Yale Food Addiction Scale. And so think about the patient, Sarah, who we had earlier on, who asked, hey, could I have a food addiction? And you as a provider have a tool that you can say, okay, let's fill out this tool and let's see. And these are some of the questions that are asked on the tool. Like when I started to eat certain foods, I ate much more than planned. I ate even though I was no longer hungry, right? I ate to the point I felt physically ill. And so this tool is free on the FAST Lab. It's University of Michigan. If anybody can download it if they want. And so there was also a study, there have been several, looking at what foods are what foods cause issues. What are the foods that people are having problems quitting more frequently? And it's not surprising, right? We have chocolate and ice cream and French fries, pizza, things that you think of and you're like, happy. I don't know about you, but I like food. So things that you think of and you're happy, and not necessarily carrots and cucumber and broccoli. Those bring their own joy, but not on the levels as these can with the reward pathways. How prevalent is food addiction? This is one of the most recent studies. There have been studies over the years. At one point, we thought food addiction was about 14%. And so this is a study from 2022, and the authors actually updated it in 2024. So that's why you have, and I'll explain this, different frequencies. They went back and looked at their data and said that actually when they had evaluated the data, they hadn't looked at certain things, so that the rates of food addiction were actually higher. And this is a meta-analysis. They had to do a correction based on their analysis. And so they said in the general community, food addiction rates are about 14%. But when you're looking at clinical samples, so clinical samples of people like with obesity or overweight, or people who think that they have food addiction, then we see rates as high as 40%. So I think if you don't remember any data today, it is that food addiction rate is about 14%, which is similar to what we find with several substances, including opioids, including stimulants. And the prevalence in children is actually higher than we find in many substance use disorders. So we should be thinking not just of adults in terms of food addiction, but children. So we're finding that children are exposed to a lot of food advertising, a lot of sweet foods, a lot of ultra processed food. So we need to start thinking that from childhood, maybe we should, when we're talking about policies and things to prevent food addiction in the younger generation, we should try to modify things to ensure that our kids are not now struggling later in their life, trying to eat less ultra processed foods. And so I'm going to be talking about eating disorders and their relationship to food addiction. So this is like a reminder of the DSM-5 criteria. So under the feeding and eating disorders, currently we have the big ones, right? Anorexia, bulimia, and binge eating disorder. And so I wanted to also make sure we don't forget like night eating syndrome, which is under other specified feeding and eating disorders. There are a lot of articles trying to compare the relationship between eating disorders and food addiction, because the question is, when we're talking about food addiction, are you sure we're not just talking about another eating disorder? Or maybe food addiction is binge eating disorder, but we're trying to call it a different name. So we'll be diving into that.
Good.
And so the prevalence, still looking at that study from Praxedes, I hope I said that name well, in 2022, was that the rates of food addiction in individuals with eating disorders, and this has been replicated in several studies, saying that the rate of food addiction in patients with bulimia is the highest at 84%. And that with binge eating disorder, we're seeing patients with binge eating disorder as high as 63% of individuals with binge eating disorder have an overlapping food addiction. And this is using the Yale Food Addiction Scale in these studies. And in weight disorders, we're seeing higher rates of food addiction in patients with obesity, patients who've had bariatric surgery. And we can also see food addiction in patients who are normal weight. So food addiction does not correlate with overweight. As much as 11% of people with a healthy weight can have food addiction, can meet high scores on the YFAS. And we're seeing a higher frequency of food addiction in patients with severe depression, PTSD, ADHD. Some studies have shown it's higher rates in older individuals. Some studies have shown higher rates in younger individuals, and mostly a female gender, although there have been some studies that have also said maybe it's higher in the male population. So there is an overlap with food addiction and with eating disorders. And so one of the biggest questions, one of the biggest controversies for food addiction is it a substance use disorder, or is it a behavioral related disorder like gambling? Is it a substance use disorder like opioid use disorder, nicotine use disorder? And one of the things is that we haven't quite found the component of food. We talk about high fats, high sugars, high salt, but there's no particular ingredient in food that we can say, oh, it's the nicotine, oh, it's fentanyl that is causing the addiction. And so most critics of food addiction say, maybe not. And some others will say, well, maybe we should classify it as an eating disorder. But as we have seen earlier, there are patients with eating disorders who have food addiction. There are patients with eating disorders who do not have food addiction, so who do not score high on the YFAS. And some people have said, maybe this concept of food addiction is a prognostic value to say, oh, maybe this individual with binge eating disorder has a more severe disorder than someone with low scores. So talking about binge eating disorder, because there have been a lot of papers trying to compare binge eating disorder and food addiction because they seem most similar. So binge eating disorder is recurrent episodes of binge eating. And what it shares in common with this concept of food addiction is loss of control, continuing to use despite negative consequences. But in binge eating disorder, you don't find the behaviors that you will find in bulimia, like purging. And so for a binge eating disorder and food addiction, right? So they bear these similarities, where a binge episode has a specified time frame. You ate a large amount of food in this amount of time. So food addiction does not have a time construct, but binge eating disorder does. And so, but we're finding that not every patient, like I said earlier, with binge eating disorder has food addiction, but we find that patients with both have higher rates of low self-esteem, depression, negative affect. So you start to also wonder about what is it about certain individuals who have higher risk of eating disorders or food addiction. Could there be things that we can try to change to help a patient who may have higher risk for an eating disorder? We should start to look at the environment, right? It's the environment, it's a lot of food, but we should also be looking at stress, emotional regulation. We think about impulsivity too. So imagine you're at work, someone brought a box of donuts. Can I really stay away from those donuts? Or do I start eating almost mindlessly? Sometimes it's like, oh, I take one, I can't stop. Oh, I take another one, I can't stop. So the loss of control you can find in both disorders. So there's, and I try to read a lot of papers about this, and there's no clear cut, oh, they're two distinct things. No, it's like they have a lot of similarities, but we also think that they may be different. So there are parallels between substance use disorders and food addiction. As much as we don't think, or as much as there is a question about have we identified the particular substance in foods that cause people to be addicted. Think about tobacco leaves, nicotine. And nicotine, because for several years there was a question about, is tobacco really addictive? Because people have used it for centuries, they haven't gotten addicted. But when you talk about how nicotine got broken down, got modified, concentrated, put into a cigarette, and put in with other additives like menthol, which we'll talk about in a minute, and not just the nicotine, put in it with several things, but also smoke in it, right? The route of delivery makes someone more prone. The rate of delivery, the rate of absorption. So if you put a nicotine patch on a patient, it doesn't hit the reward center the same. So that's why the proponents of ultra processed foods say this has been changed. This is sometimes it's not even really the food that you started out with. It's so much more different from what we started out with. Hyper concentrated, hyper palatable. And also, like we were talking about, looking at, so we talked about the substance, looking at the individual risk factors, the environmental risk factors. It's available, it's accessible, and also having individuals who are more prone, who are more at risk, either because they've had a family history of addiction, they themselves have a history of addiction, right? So we have patients who've tried to quit cigarettes. And I started to think about when people gain weight, and I haven't looked into this at all, when people gain weight after they quit cigarettes, are they quitting? Because we do know there are pathways where they start to gain weight, but I'm also starting to wonder about, is it almost like there's a replacement of one substance with another? And maybe we should start to look into that and start to talk to our patients about that. And another parallel would be the behavioral symptoms. So we talked about this a lot. Use despite negative consequences, cravings. There's a study that showed that cravings using the YFAS, the Yale Food Addiction Scale, was one of the highest correlates with food addiction. And sometimes it's not even that after the food was eaten. So you can crave that substance. And imagine how many times the patient has told you, I wanted that cigarette so bad, but when I had it, it wasn't more pleasurable than anything I had had, and when they have looked at the brains of people with food addiction, sometimes after they've had the substance, it didn't light up differently on a functional MRI, but it lit up differently when they were craving the substance. But by the time you had it, it wasn't almost like it wasn't really about the substance, but it was about the dysregulation of the reward pathway. And so there are a lot of neurobiological findings and a lot of neurobiological similarities between substance use disorder and food addiction. And also, one of the other things with the rate of delivery is just thinking about after we stripped the foods down, after we've broken them down, we've taken out the nutritive substances, we've taken out the protein and the fiber. And sometimes even when you eat the food, right, it's almost like it melts in your mouth. And it's like it was almost like it's broken down for you, and it will be delivered faster into your gut than if you had eaten like an apple or other vegetable. And so thinking about, so one, in the definition of food addiction, in the definition of ultra processed foods, we talked about additives. Foods have been broken down through a series of industrial processes, and things have been added to even change it from what it was before. And we have found that with nicotine, right? Nicotine has a lot of additives, one of them being menthol. And menthol is important because even though the cigarette burns, menthol kind of cools that down. So people can take a longer draw. And so smoke longer, smoke more. And we know, well, I've dug into this, that menthol was marketed towards minority populations in terms of advertising. This is one of like the adverts from years ago, targeting young Black population to be like, this is cool, this is good. So it's the same thing that we're finding with ultra processed foods, where all of these things, texturizers, sweeteners, salt, have been added to make that more pleasurable. So we talked about some of the critiques of food addiction, right? It's still very controversial, and we haven't identified the addictive substance. And also, food is essential for survival. But then the question is, are ultra processed foods essential for survival? Right? And so studies are showing some physical withdrawal. But there's a great article, actually, this one by Fletcher and Kenny. They say, is food addiction a valid concept? They said, we should think about, was it the withdrawal symptoms? Was it from not having the food? Or is it that scarcity mindset of, I don't have this food is only available for this hour. I'm not going to have it again for 23 hours. So let me binge on what I have right now to store for until whenever I get some more food next. And so we also talked about the overlap between food addiction and binge eating disorder and substance use versus behavioral addiction. What can we do? What can we do? The changes here in terms of our food environment has changed. These foods are all around us. And I was listening to a podcast where Judd Brewer, who is a neuroscientist and a psychiatrist, was on, and he said the system has failed us. And he was talking about how accessible these foods are, and how there are some, there are people who are more prone to, I can't just walk away. I can't just look past this. I'm always seeing cues in my environment. So some people say, like our patients, I know patients, I've had a patient who said, I would love to drink a beer once a year, but every time I take a sip, then I black out for days. And so I have come to learn not to even touch it at all. And so some people are starting to think about that with food, because you always hear about cheat days. But now people are starting to say, once I get that cheat day, I go into this vicious cycle where for weeks on end, sometimes for months on end, I cannot stop. I just keep coming back to ultra processed food. I cannot stop. And so some people are even saying, I'm a food addict. I've known not to touch things. I have to plan ahead before I go to a party. I have to let people around me know that I'm not even going to taste it, because once I taste it, then I just keep going. So some of the policies kind of like we did with nicotine, where we increased taxes on food. So things to think about: shelf labeling, increase in taxes, providing more healthy school lunches for kids, right? The TV ads, so we're not bombarded with these images of ultra processed foods. And of course, is providing healthy foods, because I can talk all I want about, oh, you should eat healthy, but the truth is there are people who may not be able to afford healthy foods. Sometimes I walk into the store and I look at prices, especially nowadays, right? You look at prices of certain foods and you're like, is that real? And so there are patients who cannot afford, and this is their life. These ultra processed foods are cheaper, they're shelf stable. I may not be able to refrigerate vegetables. And so I need easily accessible foods, cheap foods. And we also have food deserts, right? In Minnesota. Where there are certain communities that's like everywhere I turn is a grocery store. There are other communities that there are no grocery stores. Or when you go into the grocery store, the section of vegetables is so small and everything else is big. The ultra processed foods are just stacked on the shelves. So we have to think about those things too, about food insecurity when we're speaking with our patients. Some treatments that have been proposed, kind of like our substance use disorders, peer support, CBT. We talk about mindfulness a lot, kind of like the PCP told their patient, hey, keep a food journal. Maybe we need to find out, what are the foods that you're eating? What are the cues you're having? What time of day are you eating them? What are the habits that you formed around the food? Oh, it was a busy day. I was stressed. I didn't have a snack or healthy food around, and I resorted to an ultra processed food. So mindfulness, sometimes even thinking about that bag of chips or potato chips. I had one or two, and I was full, not just, oh, I kind of mindlessly ate the whole bag. So just thinking through when we're eating and thinking about harm reduction, kind of like, okay, maybe you can cut it all out. Maybe we can decrease the amount of ultra processed foods that we're eating or that we're putting in our diet, or finding your trigger foods. If you know that it's sweets, maybe cutting down on sweets, or trying to, wait, what is life without sweets though? Trying to remove sweets from your diet. So some things that you could start to talk to your patients about. And so we're also seeing, right, more and more talk about GLP-1 agonist, talking about naltrexone and bupropion combinations, and also finding out for that particular person, what are your triggers? Like we said, what is your environment? Because there are associations between stress and cortisol and the hormones that make us want to eat more, ghrelin and dopamine. Is it depression? Are you dealing with depression? Maybe if we treat you with depression, then you won't, or treat how to cope with anxiety and negative emotions, then maybe you won't use food as the treatment for that. So some things to think about, identifying the nutrients like we talked about, and considering more research. Some people say, if this becomes a criteria of a substance use disorder, then if we have an official diagnosis, we can diagnose patients, we can help patients, we can do more research. There's still a lot more questions to be answered about food addiction, the relationship between food addiction, obesity and eating disorders, and also talking about our patients with food insecurity and food deserts. We have to help a holistic look at all of this. And, this topic is also to expand our scope of practice, to know that there's something like this out there that we should be thinking of when we're caring for our patients. All right, thank you. And these are my references.
If people have questions, you're welcome to chat them in. There's already one in there. I'll just kind of touch on. Otherwise, you can unmute, because I also have about 40 questions written down here. But, somebody asked if you have any examples of texturizer. And honestly, that made me think of Swiss rolls, which may or may not have been a problem of mine in the past. But Swiss rolls, you talk about texture. That's plus it mixes you. If you remember the comedian Louis Anderson, he wrote a book about his food troubles, and he actually talked about unrolling Swiss rolls and scooping them up with potato chips. That was his favorite snack. And he would literally buy those by the case. He would buy those he clearly had an issue with that. But what did they use for textures?
Most of these are industrial chemicals.
Huh.
Again, not what you would bring off your shelf, not the meat tenderizer.
Sounds healthy.
So no, I'm sorry, I don't know. I could try to look more into it, but it's very possible we won't find it. There are a lot of trade secrets out there. And also, I see another question: how do you differentiate between food addiction and binge eating disorder? I read several articles trying to differentiate them, and it was almost like a loop. At one point, I believed they were the same, and then in other articles, I'd be like, okay, there are differences here, but I think it's worthwhile continuing to explore. And there are two different instruments. There's a binge eating disorder instrument, and there's the Yale Food Addiction Scale. And they have used both on patients and see that even the same patient has different things that they tested differently.
I'm going to ask one other question here, and then I know you've probably got questions. The rituals, when you think about addiction, you think about ritual. Do you think food preparation is part of the ritual, or is it going to the gas station to get those little Debbies, which are mentioned in the chat? Also, I'm not going to talk about my little Debbie issues, but yeah, I mean, how about rituals?
Yeah. I think it depends on the individual. With nicotine, I have started to talk to my patients more as I've learned more about nicotine, about why do you really smoke? Is it really pleasure, or is it the rituals you've formed around it? I wake up in the morning, I have a cup of coffee, I have a cigarette. And it may be things like that too. In the morning, there are days, honestly, I'm driving to work, 7-day hospitalist shift. By day 5, I'm like, I need a reward, And so those are some rituals everybody has. So it's trying to identify them.
I think something that intrigued me is the use of antidepressants. I've always kind of recognized the correlation between maybe being anxious and binge eating, because for myself, that's definitely a thing. But I hadn't thought about depression and dopamine and issues with foods. So are there any antidepressants that are better than others for treating any eating disorders, or what would you recommend for that?
I can definitely look into that more, because some of the antidepressants that we're talking about, like with serotonin, reuptake inhibitors, right? Having more, what's the link between serotonin and dopamine? Or something like Wellbutrin that's almost stimulant-like, which is why I think it's combined with naltrexone is that appetite suppression while also helping with depression.
Yeah.
And so I will be looking more into that too, to see are there particular antidepressants that we have identified for eating disorders that are better.
I have another question. If you want to, you can unshare if you'd like to, just so everybody can see everybody. One of the things, if you look at certain substance use disorders, you're much more likely to have, if you have one substance use disorder, you're more likely to have another. How about with, eating? If you've got potentially a food addiction, are you more likely to have another substance that you play with?
So from looking into this, there are individuals who have higher risk for this, maybe because they're already dysregulation in the dopamine pathway, in the reward system, mesolimbic pathway. But we also have individuals like, I am fine, I have no issues, but I cannot stop eating. So we're seeing both in the data.
There was a note in the chat that said, I heard from people traveling or staying in the UK that they banned certain preservatives in their country, and she would actually send her daughter the Little Debbie's because there's things that they don't sell there, right? And that kind of brings that whole thing. And so why do you go to Europe and everybody's lean, right? How does that, is it cultural? Is it genetic? Is it they limit some of the availability of these things? I mean, let's face it, Little Debbie's are available on every corner where there's a gas station.
I think about red dye. Isn't that banned in Europe? Does anyone know?
Look as good, yeah.
What's that?
So things don't look as good, right? You can't make them look enticing, right?
And a friend of mine just returned from Canada. They drove across the border and drove back, and she was like, I went to the grocery store there. I was so surprised. Everything is labeled down to the detail. Foods appear more wholesome. You know what's in the food, and I'm like, right across the border. And, it always makes me think about, what do we not know? Because even with formula, when I had my baby, people started to talk about, hey, you should get European formula if you want a formula instead of US formula. And I'm like, what are you talking about? And they said the standards are different. There are things in the US that we allow in certain foods that is not allowed in Europe or in Canada. And so nowadays I'm looking at food with suspicion.
Interesting.
Katie
I would like
commented.
to,
Go ahead.
Oh, sorry.
Erin, do you want to go ahead?
No.
Sure, I will. Katie just commented that Fruit Loops in Canada are vastly different than in the US.
No, I was just gonna say, I'm sure like a lot of moms on here, maybe you follow all these like things for your children, like what's really in their snacks and looking at like ingredient panels and everything. And it's just like mind boggling, like oatmeal cream pies, there's red dye number 40 in the cream. It's like, it's white. Like, why do you need to put red dye number 40 in an oatmeal cream pie? Anyways, that's kind of off topic, but it is eye-opening.
Mm-hmm.
Go ahead, Tanya.
I think it is interesting. I've been in the recovery field for quite a few years, and I've had a lot of opportunity to try many different, like from management withdrawal to all sorts of different types of continuation of care. What I did find interesting is the correlation of the number of individuals that would access the methadone clinic in St. Cloud who also had gastric bypass. And the reason it was so recognized is because of digestion and how they metabolize the methadone differently due to the gastric bypass. And I just thought, like, I rarely meet people with this procedure, and yet I'm at a methadone clinic and it was way more prevalent than any other treatment venue I may have worked in. Is there any correlation with opiate use disorder and eating with like a specific substance? Because, and you would see it a little bit for alcohol withdrawal. I did see it much more though in a MAC clinic.
Yeah, so several things come to mind with gastric bypass. I know just a little bit on the correlation between gastric bypass and alcohol. With gastric bypass, patients discover that, oh, when I drink alcohol, it gets to my brain faster. I can drink less and become intoxicated. And so I have had patients with alcohol use disorder, which started after their gastric bypass. But with opioids and food addiction, so there are two systems for reward almost. The endocannabinoid system, which we have in our bodies, which are like opioids, and then the dopamine reward system. So we have both of those. So some of the work for food addiction actually started after people were looking at opioids and were like, oh, the food addiction is very similar. It follows the same pathways. We're seeing that in brain studies. So we are seeing that.
You know, it's interesting because I read something once and they talked, and I've seen this in the clinic where you'll see people who really carbohydrate, they just crave carbohydrates when they're using opioids. And I've had a couple of these patients who've been very, very heavy, who lost, literally stopping opioids, the one guy lost almost 100 pounds, which normally we're watching their weight. And if they start losing weight with opioids, you're thinking, oh, they relapsed, right? And there's some weird connection there. And I've never really looked into it and I don't know if anybody else on the call has kind of dealt with that. I mean, again, most of the time with the opioid patients, because they're not eating as much, they're constipated a lot, they don't feel good, they don't eat much, but there's this subset that crave carbs. And actually, specifically, the two patients I'm thinking of both went to McDonald's. That's all they ate. And as soon as they were off opioids, they didn't crave it anymore, which was weird. I don't know, anybody else ever kind of run into that? Yeah. Are there other questions on there, Katie or Aaron, that you see?
A comment by Jody. Traveled to London with my husband in 2016. I did not see one overweight person walking on the streets. It seems like they walk a lot and they don't rely on driving to get around. But I did notice that a lot of people were smoking, which is not a good habit and probably negates the exercise they are getting. Interesting.
Yeah. Other questions from anybody?
This is Matt, just a quick comment. You must have been in an area in London where there were no American tourists.
Yeah.
We just got back from Europe and there are a lot of big people there, but I think they're all with us. So,
yeah.
The cynic in me tells me that once the FDA approves a patented medicine for food addiction, it'll rapidly get inserted into the DSM-5R, whatever we do next.
Interesting. Yeah.
Right now, the combo of naltrexone bupropion, that's not patentable. That's just going to be what you put together with your pharmacist.
Yep.
I know in some of the communities that Kurt and I work with, some of the addiction docs are getting into weight management a little bit and some of the injectables. And it's interesting, we know that obesity causes such a huge amount of other chronic illness, but it's not covered by insurance off-label for weight management, which I find really interesting because that's kind of harm reduction in and of itself, I guess. If you know that you could potentially get high blood pressure or heart disease or become diabetic. So I'm curious to see what happens with the injectables and insurance coverage and all of that type of thing, especially learning about today that it mimics a lot of the behavior of other substance use disorders.
Yeah. Well, we are about out of time. Any last comments? Anybody else? Any other thoughts before we go?
Thank you for bringing me on. Thank you.
Dr. Agenta, that was fabulous. You are welcome to come back anytime you want when you have another talk. This one was great. Really enjoyed it.
Thanks a lot. Thank you for having me.
All right, everybody. We will be talking about marijuana and pregnancy next week. It'll be just tons of fun. So feel free to come back. And anything else, Aaron, that I'm missing?
I don't think so. Kurt, you know that Tanya is my cousin, right?
Oh my gosh. you got Rellies on here.
I got Relly's on here. Yep.
All right, everybody. Have a good week and reach out to us if you need to for anything. We're glad to help.
Bye, everybody.